Hi there, and welcome to this presentation. My name is Dr. Pam Durepos, and I am a professor in the Faculty of Nursing at the University of New Brunswick. And I'm very excited to talk to you today about collaborations with various healthcare workers and departments. I have been here at the University of New Brunswick for about 3.5 years in the Faculty of Nursing. Prior to this, I was at McMaster University where I did my doctoral work, and I have been a registered nurse for 20 years this year. And prior to getting into academia, I practiced in neurotrauma intensive care at the Hamilton General Hospital. And so I'm excited to talk to you today about different areas of my experience with collaborations. My research primarily focuses on helping staff and family members and residents experience and implement a palliative approach to care that really focuses on quality of life and smoothing transitions and just holistic wellness throughout the illness trajectory. Particularly when people are aging or living with a chronic illness. So what I'll say about myself there. And I'd just like to start with a land acknowledgement. At UNB, we carry out our work on the traditional unceded territory of the Wolastoqey, Mi'kmaq, and Passamaquoddy peoples. This territory is covered by the Treaties of Peace and Friendship, which these nations first signed with the British Crown in 1726. The treaties did not deal with the surrender of lands and resources, but in fact recognized the Mi'kmaq and Wolastoqey title and established the rules for what was to be an ongoing relationship between equal nations. So we pay respect to the elders, past and present, and descendants of this land. We honor the knowledge keepers and seek their guidance as we strive to develop closer relationships with the Indigenous people in New Brunswick. And I think it's very important to acknowledge, the guardians and the Native peoples on these lands, not only here in New Brunswick, but also I know there are people joining us from Nova Scotia. Especially in the field of healthcare and research, we have a huge responsibility to enact the calls to truth and reconciliation. And there's still a lot of discrimination and inequities that Indigenous people experience in all sectors, but especially in healthcare, where it's most dangerous for people to experience that. Okay, so I was asked to speak today about collaborations. And so I'm very fortunate to be able to speak about this topic from two different viewpoints, both through my experience as a healthcare provider and then also as a researcher. So within the healthcare workforce, of course, as you know, it's a complicated kind of landscape. And at any given time, working in healthcare, you could be working with, as many as, 4 or 5 different disciplines, different job titles, and different scopes of practice. And that can make for very complicated, team dynamics sometimes. Usually for the positive because of the diversity. However, it's good to acknowledge who all the different players are in the room and to be familiar with them. So, of course, we have a variety of healthcare workers who are both regulated or unregulated, also known as, licensed or unlicensed. And that has a huge impact on their scope of practice and their level of knowledge and their level of responsibility. However, I would argue that every single person who has something to do with healthcare is an essential care provider. It is definitely a team sport, and none of us can do any kind of task or fulfill our responsibilities alone. So we really need to recognize and value one another for the, the strengths that we each bring. As I mentioned, healthcare is a very complex landscape. There's differences between, organizations, differences between sectors in terms of long-term care, community care, primary care, acute care, and those differences can vary even between the region that you're working in, or the province, or the country, of course. And it's surprising how different they can be between, areas, even in New Brunswick, that are not that far apart. However, they can be, managed somewhat differently, or have different resources that really influence a care delivery. And of course, healthcare workers are constantly under demand. Priorities are always having to shift, from day to day and from minute to minute. And there are a lot of competing demands. So whatever format of relationship or purpose of relationship that you're working with a healthcare worker in, whether that be researcher or alongside them as a fellow, health professional, or as a family member or patient, it's just important to recognize that they're generally carrying a heavy load and have a lot of balls in the air, and I think there's a lot we can do to facilitate one another in each other's roles, and then also just to be appreciative of what people are doing for us when we ourselves need care. So specifically, when we look at collaborating with healthcare professionals, it's important to recognize that healthcare professionals are generally educated and trained with varying worldviews. And that may even vary, between professionals that are trained at different institutions. For example, some schools of nursing subscribe to a particular nursing theorist, and that may be then something that they really value, in the profession if they graduate from a certain specific school. There's a lot of contrast between, a medical model versus a biomedical model versus a more holistic model or a psychosocial model of health. And so that's really going to influence the way that healthcare professionals approach a client and their family, and the way that they approach treatment and goals, perhaps, in treatment. And so although we can never really be 100%, clear on what other people's views are, because of course that's going to be diverse within a discipline itself, I think it's very helpful to, learn about how people approach problems differently, because it just makes us more tolerant and more understanding, and we can recognize the strengths that each person kind of brings to the situation. Each discipline, whether it's medicine or OT or PT or nursing or social work, or even research, it is identified as a discipline partly because it has a unique body of knowledge. We are each governed by different standards of practice. We each have our own ethical code of conduct. And I would say that the professional identity is slightly different between each of the disciplines. And so where we have lots and lots of things in common, there are subtle differences within each discipline that are going to influence how people behave and the way that we approach working in a team and the roles maybe that we feel comfortable taking on. So I think that those are things, maybe not necessarily to, have a ton of information about everyone's different roles, but to be aware of. Because it definitely comes out in our interpersonal relationships and our interactions. So I looked up for this presentation, just what exactly does this word collaboration mean? I think we use it a lot. I tend to think of it as just, teamwork. Um, but there is an actual model, of course, that there always is a model, and I love models um, of collaboration. And that includes characteristics of it being mutually beneficial, there being a well-defined relationship, having shared responsibility, mutual authority and accountability, and sharing both the resources and the rewards. But what's most important in a collaboration is having mutual goals. And I think that goal may differ slightly between, professionals or healthcare workers or providers or members of a relationship, but they need to be aligned, in some way of what we're working towards, and whether that's, getting a patient home from hospital, or that it's, collecting a certain amount of data so that we can better understand an intervention, or, auditing patient charts to identify areas for improvement and documentation so that we can reduce, I don't know, errors or inaccurate documentation. Many of them, I would say, in healthcare are really focused on, improving patient outcomes, improving health system flow or processes. And that's, for the most part, something that everyone can get behind. But it's very helpful if it's a mutual goal that we can identify together. So we kind of have this shared purpose. And so then going a little bit further from that idea of collaboration, another definition is that when we speak about interprofessional collaboration, that really refers to a partnership between a team of health providers and the client. So the client is an essential member of this collaboration. It's not someone we're collaborating about, it's someone we're collaborating with. And they, in fact, should be the leader of their own care and within that team. So I'm not sure if you've seen this before. It is over 10 years old. However, I was introduced to this during an internship that I did a few years ago with the Canadian Frailty Network. And there was a big focus on leadership and interprofessional collaboration. As a graduate student, I was placed in a team with other graduate students at varying levels of their schooling across Canada. And some of them were from, again, OT or PT or social work or spiritual care or health research methods, epidemiology. And we were working together on projects related to aging. And we had the opportunity to kind of identify a project and then work on that project over 12 months together. And during that time, I received some training, both in leadership and interprofessional collaboration. And I was introduced to this model. And it's, at first glance, is kind of complex because there's so much writing. But I can really relate to these major concepts. So we have, our goal is that we're having this sort of positive interprofessional collaboration and things that will, I think, affect or influence, the extent to which we're able to really successfully reach that goal are how clear our roles are, how well we're able to resolve conflict, having a collaborative leadership style where leadership kind of shifts from person to person and it's shared. It's not a dictatorship or a hierarchy in any way. And then it's also influenced by team functioning. So those ideas of group work and dynamics, we never escape them. So for students that hate working in groups in your classes, well, this is a lifelong skill, and you know, it's nice to do things independently, but we are definitely stronger together, and really can push each other's perspectives and you know, often help each other achieve a goal. Okay, so some of the questions were really about, you know, some of my practical experiences. So I thought it would be helpful to just share a couple of stories that kind of show different ways that I've collaborated through my career thus far. So I selected one example to share with you first, which is what I called a journey in successful healthcare collaboration. So from my time as a nurse. And so I'm a nursing professor. We use case scenarios all the time, and I think it's a wonderful way to learn, and stories tend to stick with people. So I'm going to introduce you to a patient that I cared for, and I've changed his name, but the other details of the scenario are real. This is Mr. Hamilton, and Mr. Hamilton was a 65-year-old man that I cared for in the intensive care unit at the Hamilton General. He was white, he was of European descent, he was married with 3 adult children when I met him, and he was a retired financial planner, and he had no significant medical history. However, unfortunately, when I met him, he was being transferred back to Canada via air ambulance following a spinal cord injury at the level of C6, so that's cervical spine 6, so quite high up on the spine. And it was a very devastating injury for himself and his family. So this is not going to be a detailed medical lecture, but just for, you know, the most important purposes of this scenario, Mr. Hamilton did become what we call a tetraplegic. People previously were called quadriplegic, but now the preferable language tends to be tetraplegic, meaning that he was unable to move his arms or his legs. C6, you can see, is kind of in that pink area of the model there, and so he had no movement or sensation below that level of cervical spine 6. But however, his goals were to return to his family home, and he lived outside of Hamilton in the Niagara area, and together with his family and within the healthcare team, our goals with him were really to optimize quality of life, optimize physical function and independence, support his emotional well-being, and really enable his family members to meet all of his care needs at home, since that was both, you know, his wife's goal and his goal. And what was really significant to know about his diagnosis is that when people have an injury at the level of C6, there's often an impact on their ability to breathe on their own. So it can interfere with the lung capacity. Sometimes the stimulation of the diaphragm can be affected. But in his case, it was more about lung capacity and ability to have a very strong cough because you have limited use of your abdominal muscles. And so because of that, he required assistance from a mechanical ventilator. We also call it a respirator, basically where he would need that for the rest of his life to be able to breathe fully, and to help keep his chest and his lungs clear. So that dependence on a machine like that is a huge blow to someone's independence. It usually means that they will never be able to be alone again, for fear that something could happen to this machine that they are dependent on 24 hours a day. So it is a huge undertaking of both the patient and the family and the staff to coordinate a successful discharge home where a person will be cared for by their family members or someone else in the community 24 hours a day. and even the person that's caring for them is going to need access to a support in case of an emergency. So that is the journey that we were embarking on here with Mr. Hamilton in our unit. So as you can imagine, when someone gets admitted to the intensive care unit, or most units in the hospital, they come into contact with a very large healthcare team. So within that healthcare team, and this is where the collaboration really starts, is of course at the center, Mr. Hamilton and his family. We always have an ICU intensivist in the unit, and that person also usually has a fellow working with them, and one or two medical residents of varying levels. So that's sort of the physician team there. There's a primary care nurse, a respiratory therapist, a physiotherapist, occupational therapist, and they may work at different hours and not always be present in the ICU, but it just depends. Almost all of our patients do see a physio and an occupational therapist. We have a pharmacist and dietitian on staff, Monday to Friday, 12 hours a day. A social worker, spiritual care, a support staff, which includes a dietary assistant and an environmental aide. Environmental aides refer to housekeeping where I'm from. We also have a service called the SKY Patient Navigator and Volunteer Peer Mentor. So SKY stands for spinal cord injury. And so those would be folks that came around quite regularly when someone was recovering from a spinal cord injury. We also have speech and language pathology. There's always research going on within the unit. Often it's led by one of the physicians or nurses in the unit. So there's frequently a research coordinator or research nurse and or research assistant that are enrolling people into studies, talking to patients and families about, potential interest in engaging in research. And then we have lots of consulting services that may not be present in the ICU, but that are being called in all the time. And these members of the healthcare team did care for Mr. Hamilton, and so they came in kind of intermittently. And was folks from radiology, anesthesia, neurology, orthopedics, who would have completed his spine surgery, and the trauma team, because this was originally a traumatic injury. So I didn't count how many people are on that list, but I think you can see that it is a huge, complex healthcare team. And there's the sort of the core of the patient, the family, the physician, the nurse, and the respiratory therapist. I would kind of say that those are the core that are there the most. However, each of these services is really so essential to the care and also to planning for future care needs. So for our patients that are a little bit of a longer stay in somewhere like the ICU, and they're going through, a more complex recovery because they've had a severe injury. From the moment that they're stable and they're able to kind of ambulate, we often have a sort of a routine that they will follow. And, it's the patient that decides on this routine with input from when the different members of the healthcare team can come in and work with the patient when they need to. But this is something like what Mr. Hamilton's schedule looked like. So traditionally, people kind of have breakfast around 8. And so that would be the nurse and the dietary aide coming in to assist with breakfast, morning care. The respiratory therapist was very, very involved in Mr. Hamilton's case because he didn't have a very powerful cough to keep his lungs clear of secretions. That would require a lot of, we would call it breath stacking and abdominal thrusts, where the respiratory therapist works with the nurse to really try to help the patient to cough and to clear out those lungs. So that would often happen every 4 hours, that the respiratory therapist would come in and work with the patient for, say, 20 minutes to really help make sure that the patient's lungs were staying clear. Then the physio would come in Monday to Friday, usually in the morning, to assist with range of motion and exercises in the bed. And then, when the patient was stable, they would begin to be transferred to a wheelchair. So for Mr. Hamilton, he was fitted for a wheelchair by the occupational therapist, who would make sure that there was splints in place for his arms and his head was in a neutral position. So another kind of specialty skill there. And then he would generally have a little bit of a break in the morning where he may be on his own, or that may be a time that family comes in and visits him, or we often have spiritual care, who is sort of a general chaplain that may be of any faith that kind of walks through the unit and visits people that they know, welcome visitors. Or the social worker may stop in. And then, of course, it would be mealtime. For us, we had rounds with our physician and our healthcare team twice a day, so usually around lunchtime, and then again just before bed, so say around 8 o'clock at night. And so there'd be multiple members of the healthcare team there. We'd kind of review Mr. Hamilton's status, bring up any concerns or issues that we may have or that he may have, and then continuously talk about the plan each day. How are we doing in terms of our reaching our goals, and how is Mr. Hamilton's progress coming along. When it was nice outside and Mr. Hamilton was able, he would often get to go outside for a little while in the afternoon. And then something that's very important to this case was the mandatory training that his family went through in order to be competent and confident enough to take Mr. Hamilton home, because they were going to be managing this home ventilator. So that training would take place daily with the respiratory therapist, and often the Sky navigator would come to kind of support the family, because it is overwhelming and pretty frightening, especially if you are not a healthcare provider by trade. And then, later afternoon would be back to bed. The family would participate as much as possible with the nurse and the physiotherapist in using a mechanical lift to move the patient from the bed to the wheelchair, or to a commode, or to whatever, mobility device they were using. Because again, that would be education and training that the family needed to experience in order to be able to take Mr. Hamilton home. So then again, there would be supper and probably some quiet time, and then bed, and then all over again the next day. And so the reason I showed you this is really to try to give a little bit of a demonstration about how integral each of these different healthcare professionals is to the care of just one person. And a spinal cord injury is, a severe injury where it's going to require a lot of input and participation from different people. But I think it's helpful to see that. And this does not even show the other services that would be consulted or that might come in on, say, a weekly basis or a monthly basis. So for Mr. Hamilton, it was about 14 months when he went home from the intensive care unit. So it is not unusual to have people stay in the ICU for more than a year, particularly those that are dependent on a mechanical ventilator to breathe, because there are very few places that people like that can go where healthcare staff is allowed to take care of breathing machines. So in Ontario, we had some beds in the City of London that were meant for people who required long-term ventilator support, and then there were some beds in Toronto, but they were very few, which meant that we had a lot of patients like Mr. Hamilton that stayed with us for quite a while, and really required a lot of healthcare team collaboration in order to, meet their goals, for example, to go home. So even on the day of going home is a huge, a huge process of coordination. He required some home renovations to be completed that would, give him a main floor bedroom that would allow him entry into his home. So things like a ramp, needed to have the equipment in place, required a special, hospital bed. Still required ambulance transport because he needed to go home with this mechanical ventilator. And so then the healthcare staff that were traveling with him needed to be trained in that use. However, he was able to go home with his wife. And once discharged, she's followed by the community healthcare team members. So that was a real story of success. And it really required each of the healthcare workers on the team to be aware of what their role was, to follow the teaching plan that we had at the bedside, to ensure that these teaching goals that we were working towards them, that the family was being actively involved and given opportunities to practice everything. So it was a very big coordinated effort. And it wouldn't have been successful without any of those team members. Okay, just a drink there. And so now I'm just going to tell you a bit about another example. And so that was my former life as a nurse, and now I'm here as more as a researcher. And I'm working on quite a large project right now with a number of partners or collaborators. So I'm here at UNB, but we're working with the University of Moncton, McMaster University, Person-Centered Universe on a province-wide project where we are introducing the SPA long-term care, palliative care program into long-term care homes. And this is a funded Healthy Senior Pilot project funded by the government of New Brunswick. So we have quite a large research team, as I mentioned, at different institutions with different disciplines. Our main partner is the Department of Social Development. And we're having really great uptake of this project, where we currently have 61 out of 73 of the long-term care or nursing homes in the province enrolled in this study. And that success really comes from our collaboration. Most importantly on our research team is the Associate Director of Research Program Management, also called the Program Manager, Miss Daphne Noonan, who is a former executive director of a long-term care home. And her involvement in this project has been so crucial to opening doors to us and helping us to identify partners that we would not even have known existed, just because we're not within that clinical setting of a long-term care home. So having worked in that area for the past, I believe, 14 years, and as an executive director for 9 years, Daphne is really familiar with all of the players in the province, both within long-term care and also within government and the Nursing Home Association. And that has really enabled us to reach opinion leaders in the nursing homes, and to really strike a chord with staff, because coming from that area, she really understood what would resonate with staff and what their kind of needs and interests were. So in terms of our aims, we have lots of aims. We're collecting baseline knowledge on the current state of palliative care, trying to build capacity by providing education and training around a palliative approach to staff in long-term care, and mainly we're providing education around what we call the SPA long-term care program. And this program has been implemented in other provinces and shown to reduce unwanted transfers to hospital by 55%, increase deaths in in long-term care as compared to hospital, because most people would prefer to die in what they consider to be their home. So some challenges, this was one of the questions that came up. Challenges in collaborations, definitely having different professional perspectives sort of on how to approach care, what the priorities for care are. There's always different natural social groups that develop within a team and between teams, and often that's based on, you know, similarities in profession. Before I became a researcher, I have to say that probably 99% of my friends were nurses. And there's a comfort in often having a very similar worldview or having shared experiences. And so it can be hard to kind of get out of that comfort zone, although it's very valuable when you do. Communication and data sharing can be really challenging, especially when you're in different institutions. It has been really challenging for us with having partners at McMaster, partners in social development at the University of Moncton, and then also at Horizon Health Network or in the community, trying to find a way to all share data, like to share files, and they have to be shared securely, has been challenging. For the most part, we've tried to use MS Teams, but that required every single member of our team to get a UNB email account, and you know that took some time, and it's a little bit hard to navigate sometimes. The overlapping and unclear roles. We have a really large team, and everyone has other jobs and other relationships. So our project comes up a lot, and there's a lot of spin-off projects going on. And so sometimes we have to, you know, have discussions as a team about having sort of a unified front or a unified message, or needing to clarify to people in the community that, you know, maybe I'm raising a new idea, but that's actually not the project we're currently working on. We've had some partners come back to us, like nursing homes, being a little bit confused because one team member is working on an additional project elsewhere, or is, you know, maybe pitching another project. And it's confusing because there's so many of us and we're all kind of out doing one project, but also working on other things. So it really helps when we come back together as a team and kind of say, okay, you know, we're trying to increase recruitment. Here's the message that we're all going to take. If we get questions about, you know, this specific topic, they need to be directed over here or to this person, so that we try to have a sort of clear messaging, really is the goal of that. Having the different professional perspectives, we've definitely seen that in our current project, because we have recreation therapy, we have nursing, we have medicine, and the way that we each approach a palliative approach is a little bit different. So we've got, you know, for example, our physician on our team really highlights, you know, pain and symptom management and disease process, whereas our nursing champions for the province really focus on advanced care planning and how to lead a family meeting. So it's very different. It's different. It's very complementary, but we sometimes just need to remind one another, you know, what our goal is, and you know, maybe it is to, you know, focus on the medical stuff at some points, and then at other points it's more to focus on providing education around communication. But our differing disciplines and professions definitely come out in what we want to focus on when we're giving, education and training. So that can be a bit of a challenge, just making sure that, again, we're sort of all on the same page. So some effective communication strategies that we've used, and thank you again, this was a question that was raised, is to agree on a communication strategy or process, to try to have, it written down who the contact people are for when different things come in, and having a regular meeting. So we have regular meetings every 2 weeks. If we don't need it, we cancel it. There's often not the entire team there, but we know that we have that check-in point every 2 weeks to keep up with what's going on with each of the different team members. I did find a really great systematic review that looked at research studies that involved collaborations. And these were some of the principles they raised, which were to adopt a shared goal and a sense of purpose, and respect what is already working well. And that's been really important to us in this research project. A lot of the nursing homes, they have good practices that are going well. They have strengths, they have experts in their homes, and we just want to support them or give them more resources for what they're already doing. So we're going in with a very flexible approach and a very collaborative, because we also want to learn from them and value their experience, because we can help take that elsewhere. Continuity in relationships is really important when collaborating. We've recently just kind of started a relationship with Kingsclear First Nation, and we're very, very conscious of wanting to have, 1 to 2 spokespersons that are most involved with the Indigenous community, so that we can build those relationships and build trust, and have familiar faces, so that we're not trying to introduce, new settlers into their community. We're appreciative of having an invitation to be there, and we want to be very genuine and be very respectful about the number and of people that we bring into that relationship, because we recognize it's such an honor to be there. We try to be adaptable. Some of the tools, I don't have a huge, like this is what works. We've tried different tools, mainly focused on trying to facilitate communication. We're using Trello for project management, which is a great project management tool. We use MS Teams for most things. We also use Google Drive. Sometimes it's just the easiest in terms of data sharing. Depending on, security levels, we always just need to make sure that it's secure. Excuse me. In terms of leadership, I think in supporting collaboration, we sometimes have to stop our team and kind of try to clarify what people's roles are, because we ourselves get confused and our roles might change at different places in the project. For example, we have within our team different working groups, and within each of those working groups, there is a leader. And my plan to do that was to empower people to have kind of a part that they could focus on and felt ownership of. And I felt that that was important. And then we have the larger team where we're all collaborating. So that was kind of a strategy I wanted to use. I also know that having opportunities for interprofessional training are really, really valuable, so that you do kind of learn about people's alternative scopes and how they may be different than yours, and working together on projects, then you'll sort of see how you might approach things differently. Excuse me. And in terms of indicators, this isn't something that I have really tried to measure, but I know based on different empowerment models, and that some of the things listed here are directly related to perceptions of collaboration. So job satisfaction is better, retention and turnover rates are better, a sense of organizational commitment, feelings of a positive culture. And so those are kind of all on the side of the health worker or professional. And then on the side of the resident or patient or family, when they sense that there is better collaboration between themselves and the healthcare team, or even between the healthcare team members that they kind of observe, that is associated with a higher satisfaction with care and a perceived better continuity of care because it will feel more seamless to them. Excuse me. Okay, and that's just the questions there that I had listed. And so now I will say thank you so much to inviting me to this presentation, and I look forward to any other questions. And please contact me at any time if you're interested in my research or would like to chat further. Thank you.